Well, thank you, Sarah and Nan. It's a pleasure to be back doing another webinar for your group. Tonight, we're going to talk about a new exciting technology involving carbon fiber bracing to augment other types of AFOs we use to treat foot and ankle disorders. Even if you don't pursue the idea of bracing with these disorders, I think we're going to provide some interesting insight into the pathomechanics and treatment of plantar heel pain and Achilles pathologies that would make this night worthwhile. So hang in there. We're going to start the webinar, and I'm going to take questions and answers about halfway through, and then, of course, at the very end. So I thought I'd start with just kind of getting you oriented with your own clinical practice and remind you how often you resort to immobilization of certain conditions that come into your practice. And I think two very common conditions where if you're failing with your conservative treatment, or if the severity of pain is such that you resort to temporary or midterm immobilization. And the first would be a typical case of plantar heel pain that might present for the first time or might present and then require long-term treatment. But consider the case of a very typical 55-year-old female who has 4 months of heel pain, and after 4 months of treatment, the pain is not getting better. You order an MRI and you see these classic findings of bone marrow edema. At the insertion of the plantar fascia, you see marked thickening of the plantar fascia. You're contemplating surgery, but as we all know, that's a daunting task for both you and the patient in terms of outcome. And so this is a case where you might consider immobilization, at least to calm down the pain. Another case would be posterior heel pain. This is one of the more challenging conditions, particularly for sports medicine physicians. Typical patient will present with enlargement of the posterior aspect of the calcaneus. Sometimes the pain is so severe they may limp into your clinic and they're seeking relief. And certainly one of the initial considerations is immobilization, just to calm down the symptoms. And so probably the most common go-to modality is a walking boot. And in both of those cases, I would have to admit a walking boot may calm down the symptoms, but the real question is, does it provide healing? And the scientific evidence certainly debates that. And I think most of you and myself in clinical practice find that patients don't necessarily heal inside of these boots. The temporary relief of pain is not offset by healing. One of the problems is simply the fact that patients are not compliant with these boots. From the moment they walk out of your office, they want to take them off. Studies have shown that patients probably wear these boots maybe 50% of the time they're ambulating, and probably less than 20% of the time when they're inside the house. This interesting study, often quoted in the diabetes community, David Armstrong put a sensor inside of the walking boot of diabetic patients and found they only wore them 30% of the time during the day, inside the house and outside. Why is it that patients don't wear walking boots? Well, the walking boot itself sometimes poses more challenge and more threat to their overall health than not wearing the boot. We know that patients have difficulty walking in the boots. They develop a limb length discrepancy that translates proximally to the hips and the knees, commonly to the low back, and they just simply take the boots off. Elderly patients immobilized in a walking boot are challenged with the balance disorder that the boots impose and the fear of falling. Another real concern with all patients, particularly if they have to wear a boot on the right foot, is how do you drive their automobile? And you basically tell them to take it off to safely drive, but that's a cumbersome task, both taking it off and then putting it back on when they get to their destination. This is a news clipping from a local newspaper near my office, where a patient, I'm on a coastal community called Seal Beach, California. And in this area, a patient actually drove her SUV through a guardrail of our local marina, and the car submerged into the ocean Luckily, the patient was able to roll down the window and escape. When the police arrived and wanted to know why she drove her car through the guardrail, she said she was wearing a walking boot and unable to control the right foot while driving the car and putting the boot on the brake pedal. The brace system I'm about to introduce you to gets around those challenges because by simply removing the two straps around the upper leg, you have full flexion of the ankle up and down to safely control the brake and the accelerator of the car. So you don't have to take the boot off, you simply loosen the straps. This is a big deal, particularly for the right foot when driving a car. So I'm pointing out the numerous challenges of wearing walking boots and the fact that particularly in the long run, healing of these injured structures is augmented by actual motion of the foot inside of a carbon fiber AFO brace rather than be locked in to a rigid boot. I'm going to show you a video comparing the advantages of a carbon fiber AeroSpring brace over walking boots. And this will ring home some of the challenges that I just brought out.
Introducing the AeroSpring bracing system, the antidote to the walking boot. Here's why. The ordinary walking boot is heavy, has significant limb length discrepancy, significant gait disturbance, cannot drive a car, significant balance comp, zero foot support, no dynamic tendon loading, contact pressure at the ankle, and minimal reimbursement. The new Ritchie AeroSpring is lightweight, no leg length discrepancy, near normal gait, can drive a car, minimal balance compromise, total foot support, alignment, dynamic tendon loading, no contact with ankle, and a handsome reimbursement. Introducing the Ritchie AeroSpring bracing system, the antidote to the walking boot.
So that'll pique your interest, and we have 4 systems. We may discuss the other 2 in the subsequent webinar, but basically we have an Achilles offloading system, plantar fascia offloading, a drop foot system, and a midfoot offloading system for Lisfranc sprains, dislocations, and osteoarthritis of the midfoot. So let's talk about the most common condition we all see in our clinics, and that's plantar heel pain. And we've developed what I think is a very intriguing and very evidence-based, scientifically based approach to offloading the plantar fascia in a way much different than what we've all traditionally relied upon. Let's face it, plantar heel pain isn't all that easy to treat. In spite of what you read on the internet and what our patients read, it's not resolvable 90% of the time with home treatments. Evidence shows from multiple research studies that home treatment programs are successful at best 50% of the time. And even with the treatments we prescribe and implement in our offices, certain studies have shown that between 18% and 49% of patients are still symptomatic up to 1 year and even up to 5 years after the interventions we commonly employ. So for all of you who might feel a little bit of guilt or lack of success or ineptitude in treating patients with plantar heel pain, you're not alone, because we really don't fully understand this condition. We must recognize plantar heel pain is nothing to scoff at. Recent studies of the psychological effects and the quality of life effects on patients with chronic plantar heel pain shows that there's significant impact in their overall body health, fitness, activities of daily living, ability to carry out work, and their overall psychological profile. In order to really understand plantar heel pain and why we fail with most traditional treatments, we have to really understand newer insights into the pathomechanics. Most of us agree that patients with plantar heel pain have pain right at this location, the plantar medial margin of the calcaneus. And from numerous studies using imaging, ultrasound, and even histologic studies, most authorities agree that most patients with plantar heel pain have degeneration of the plantar fascia specifically at the origin or attachment to the calcaneus. So really, we want to focus on what the plantar fascia is and how it's stressed and how we can offload that stress. So research has shown us that there's three primary mechanisms that we can employ or focus on to relieve tensile strain in the plantar fascia. Most of us have looked at the arch of the foot, specifically the medial longitudinal arch. And whether it's on the internet or whether it's what we tell patients in the office, we tend to focus on supporting the arch because somehow we believe that the medial arch is involved in the pathology. What is often overlooked and what has really been brought to light recently is the role of the first metatarsophalangeal joint via the windlass mechanism. And what we have recognized for many years is the role of the Achilles tendon. Let's look at the arch itself. The simple concept of putting a medial arch support under the foot is not specifically addressing the tensile loading on the plantar fascia. Many of us have provided the best foot orthotic we can, the perfect arch support, and the patients do not improve. Why is that? What are we missing? What we're really missing is understanding how the plantar fascia is overloaded with arch failure and whether it's purely linear strain and whether it's really due to the medial longitudinal arch. A very respected researcher in Australia has conducted numerous studies on the pathomechanics of plantar fasciitis named Scott Waring. And he has shown that the scientific support for medial arch failure has really limited evidence to support that finding. In other words, he really looks at non-uniform loading or twisting of the plantar fascia, bending, shear, and compression as contributors to the development of plantar fasciitis, not just simply strain from linear failure of the longitudinal arch. I've looked at this closely in my career, and I go back to one of the most sentinel articles in this area published by Serafian back in 1982, called Functional Characteristics of the Foot and the Plantar Aponeurosis under Tibio-Talar Loading. And Serafian was among the first to show that the simple truss model of the human foot with plantar fascia strain is not accurate in terms of overall description of the motions of the foot that strains the plantar fascia. Serafian took a cadaver and he loaded it on a frame with full body weight, and he rotated the tibia into internal rotation, which pronates the foot. And with photography, he showed that indeed the plantar fascia, as well as the abductor hallucis, underwent elongation strain. He took that same cadaver and he externally rotated the tibia, which supinates the foot, and he noted that the plantar fascia became relaxed, or as he said, undulant. So this underscores a notion that we all understand: pronation strains the plantar fascia. But the simple term pronation is misleading because multiple joints in the foot undergo motion when we internally rotate the tibia. When we look at a foot like this that appears fully pronated at the subtalar joint, we have to recognize that it's also supinated to an equal degree at the mid-tarsal joint. Years ago, back in the 1920s, Steinler described this reciprocal pronation and supination of the forefoot and the rear foot. And as the rear foot supinates, the forefoot pronates reciprocally. Or pronate or supination of the forefoot actually causes pronation of the rear foot. That's a concept that many of us never learned in school, but Serafian brought it out very succinctly in his article. Pronation of the forefoot causes supination of the rear foot. And therefore, an interesting approach to relaxing the plantar fascia is to pronate the forefoot. This was underscored years later in a series of very, very important studies published by Kogler et al. During the late 80s and early 90s. Specifically, this article titled "The Influence of Medial and Lateral Wedges to Load and Offload the Plantar Aponeurosis." Kogler took 9 fresh frozen cadaver specimens and applied axial load with body weight on a frame. And he placed wedges, either medial or lateral, under the forefoot or the rear foot. And he wanted to determine whether these reduced or increased strain in the plantar fascia. This is his experimental apparatus with the cadaver lower limb. He placed 6-degree wedges, either medial, as you see in this picture, or lateral under the forefoot and then under the rear foot. And each time he put a wedge, he measured the strain in the plantar fascia. I would ask the audience, if you had a wedge and you were allowed to place it somewhere under the foot, where would you place the wedge to relieve strain in the plantar fascia? And what type of wedge would you use? I think most people would look at a medial varus wedge, the idea being to reduce pronation. But if you put a medial varus wedge under the forefoot, it actually supinates the forefoot, doesn't pronate it. Indeed, Kogler found that the only wedges that reduce strain in the plantar fascia were wedges placed in the forefoot, not the rear foot. And in every case, it was a lateral wedge in all 6 specimens that reduced strain in the plantar fascia. In every case where a forefoot medial wedge was applied, it increased strain in the plantar fascia. This absolutely verifies the Serafian principle that when you pronate the forefoot with a lateral wedge, you reduce strain in the plantar fascia. The statistics verified this in this study. And another anatomist named Bojan Moller showed this very graphically in a series of photographs where he twisted the forefoot into supination on the left-hand picture, which caused tension and bowstringing of the plantar fascia. And then he pronated the same human foot, and it relieved strain in the plantar fascia. He pronates the forefoot, and he relieves strain in the plantar fascia, just as Kogler did, just as Serafian suggested. If we can pronate the forefoot, we can supinate the rear foot, and we will decrease tension in the plantar fascia. I started looking at those wedges that Kogler developed and tested, and in my own practice began using them on patients with recalcitrant plantar heel pain. And I was amazed how much and how effective a simple 1/4 inch wedge in the forefoot placed on top of the insert of the shoe or even on top of the existing foot orthotic would almost immediately alleviate significant pain in patients suffering from chronic plantar fasciitis. The wedge itself is skived, leaving the lateral distal margin highest and skived medially to end just at the border of the first ray. A wedge like this can be placed on the top surface of an insole of a shoe or on top of a foot orthotic. It was so effective in my own practice, and I was so impressed with Kogler's work, I did a patent search and found out that nobody had ever patented this idea. So I applied for and received a patent about 10 years ago, and I've been able to now license labs to apply this wedge to the top surface of any custom foot orthotic or insert. And so now we've implemented this into the Ritchie Brace plantar fascia offloading system, because one component of the system is a custom foot orthotic. It's one of the 3 components. The 3 components are a custom foot orthosis with the lateral forefoot wedge, which we've called the arch lock, graduated heel wedges, and then of course the carbon fiber AFO brace, which we're going to discuss in a moment. So the custom foot orthoses have the patented forefoot wedges, scientifically proven to offload and decrease strain in the plantar fascia following a very sound biomechanical principle of pronating the forefoot on the rear foot. By the way, we don't have to, you as the practitioner do not have to order the custom orthotics with the Ritchie AeroBrace system. Many of your patients already have custom orthotics that they can apply to the carbon fiber AFO. And in some cases where there's no insurance or there's inability to pay, prefabricated orthoses can be applied to the foot plate of the AeroSpring brace. However, when the patient has chronic heel pain and already has custom foot orthotics, we highly recommend that you send us those orthotics and let us apply the forefoot wedges or the arch lock mechanism, because I think you'll find them to be a powerful enhancement to the orthotics you've already tried. So we've talked about the new insight in the medial longitudinal arch. Let's talk about this other insight into extension of the first MTPJ. Finally, we'll end up with Achilles tendon force. So some interesting research has shown that extension of the great toe, activating the windlass mechanism, puts significant strain on the plantar fascia. And that makes sense from everything we know about the windlass mechanism. This study, published in Foot and Ankle International, showed us that compared to the Achilles tendon, the dorsiflexion of the hallux with the windlass mechanism puts more force on the plantar fascia than the Achilles, 84%, by the way, compared to only 15% by the Achilles. Up until now, most of us have always focused on the Achilles as the primary deforming force on the plantar fascia, yet we've overlooked the effect of the windlass mechanism with full dorsiflexion of the hallux. Another study verified this to the same degree. Another study published in the Journal of Biomechanics back in 2008 showed the dorsiflexion of the digits contributes 66% of the strain of the plantar fascia, while the Achilles only accounts for 33% of the strain. How can we address this strain in the plantar fascia when the digits go into full extension? One thing we've learned is that when patients go into rocker sole shoes or maximalist athletic shoes with rocker sole shoes, they receive significant relief of pain from plantar fasciitis. The reason this is happening is because the rocker sole shoe and the stiff sole is limiting extension of the digits and loading of the plantar fascia. Indeed, there are studies showing the use of rocker sole shoes significantly reduced plantar heel pain. Back in 2013 in Gait and Posture, and another study in 2012, significant relief of pain simply by moving the patients to rocker sole shoes, which many of the new maximalist shoes and so-called super shoes employ. The super shoes, the high-performance athletic shoes that were pioneered by Nike, have carbon fiber spring plates built into the midsole. We've learned that we can put carbon fiber spring plates inside of a traditional athletic shoe and achieve almost the same effect. Research has been carried out on these carbon fiber spring plates, and indeed they significantly reduce first MTP dorsiflexion. This is helpful for osteoarthritis of hallux rigidus, but also shows very interesting effects on the arch of the foot and loading of the plantar fascia. This study done at University of Calgary with Benno Nig's group, comparing carbon fiber foot plates inside of a shoe to a control group without the foot plates, gave some very interesting findings. In terms of plantar fascia loading, we find two very powerful effects: reduced extension of the first MTP and reduced lowering of the medial longitudinal arch, simply by putting stiffening carbon fiber foot plates inside of the shoe. The new AeroSpring carbon fiber brace, of course, has a carbon fiber full-length foot plate to bring to effect those benefits of the foot plate alone. But the advantage of putting the foot plate attached to a carbon fiber AFO is to address factor number 3, the Achilles tendon. The Achilles tendon does have significant effect on the plantar fascia, not as much as extension of the toes, but more so than simple arch loading. In fact, the Achilles tendon has a twofold greater effect on straining the plantar fascia than simple body weight alone. That's why patients do get better when they're put on a comprehensive stretching program of the calf and the Achilles. That has great scientific merit, and anecdotally, we know that that works and helps patients recover from chronic plantar heel pain. How can a carbon fiber AFO reduce strain in the Achilles? We go back to really the biomechanics of how AFOs, and specifically carbon fiber AFOs, work. And so we look at these phases of the gait cycle, and we look at the rocker phases that occur as the foot is on the ground. And the first thing that the AFO does is it facilitates a heel strike and helps engage the heel rocker. Then during mid-stance, it controls tibial progression during the second rocker, limiting ankle joint dorsiflexion and limiting loading of the Achilles and the calf. So right here in this phase, the carbon fiber AFO is already offloading the plantar fascia. Then a very interesting mechanism occurs during the third rocker. As the tibia migrates forward, actually in the second rocker, the carbon fiber brace deforms and stores energy, so that in the third rocker or push off, there's a recoil mechanism. So instead of the calf muscle facilitating push off, the carbon fiber brace through energy release facilitates push off instead of the calf muscle. Indeed, studies have been done on carbon fiber AFOs documenting this very positive storage of energy and release of energy during push off. These are multiple studies I'm showing you here in these slides, showing how the carbon fiber brace improves push off, taking demand away from the calf muscle and the Achilles. Especially compared to traditional carbon fiber, polypropylene or plastic AFOs, the carbon fiber has much greater ability to facilitate flexor power and push off. So 88% better energy return with a carbon fiber compared to plastic AFOs. Multiple studies continue to verify this. So by reducing muscular activity and giving a push off with the carbon fiber AFO, we greatly reduce demand on the plantar fascia and reduce loading on the plantar fascia, particularly during that all-important push-off phase or terminal stance phase of the walking gait cycle. So with the carbon fiber AeroSpring brace, we will try to enhance the first rocker. We offload loading of the Achilles in the second rocker. We help push off during the third rocker and indirectly relieve strain in the plantar fascia. So this is really an ideal system addressing all three loading mechanisms of the plantar fascia in a way none of us ever did before by simply using custom foot orthotics and the myriad of non-surgical interventions we tell our patients to do in the home setting. I think this is an exciting three-dimensional approach to treating chronic recalcitrant heel pain, not necessarily implemented for the patient with early onset heel pain, by no means, but this is designed for those patients we all have in clinical practice that simply aren't getting better or who have had heel pain for 4 months or greater duration. What about the heel lifts that we apply to the plantar fascia offloading system? Besides just a foot orthotic, we recommend at least a 10-millimeter heel raise placed under the orthosis. And there's good science behind this, because heel lifts alone, heel raise, whether it's an elevated heel shoe or a heel raise, reduces pressure on the plantar surface of the calcaneus and directly reduces tensile strain on the Achilles. Studies show that elevated heel shoes reduce pressure under the calcaneus, and that's why our female patients always come in and tell us they feel better when they wear elevated heel shoes. But we've also found that they relieve pain probably by reducing strain on the plantar fascia and via reducing strain on the Achilles tendon. A simple heel lift alone doesn't necessarily reduce pressure under the calcaneus. You have to elevate the shoe itself, not put a heel lift. But if you put a heel lift with a custom foot orthosis, studies show that indeed you reduce pressure on the heel and reduce pressure in the forefoot by raising pressure in the arch area of the foot. So increasing pressure into the midfoot will decrease pressure in the heel and the forefoot. That's a good thing for patients with chronic heel pain. So we want to decrease strain on the Achilles. We want to decrease pressure on the heel. And by doing so, we combine the effects of heel wedges with a contoured foot orthosis to increase pressure under the arch. Indeed, this was verified in another study by Kogler, who I mentioned earlier, who showed that heel elevation is most effective in reducing strain in the plantar fascia when it's combined with contour to the medial and lateral arch of the foot with a contoured foot orthosis. A heel lift alone was ineffective in reducing strain on the plantar fascia. Part of what we think we're doing when we elevate the heel and we use a foot orthosis is we allow the forefoot to plantar flex on the rear foot. And this actually effectively shortens the length of the arch of the foot and decreases strain in the plantar fascia. So our system decreases pressure under the calcaneus, decreases pressure under the forefoot, decreases strain on the plantar fascia using all of the mechanisms that I've gone through. So we address the medial arch, the windlass, and the Achilles tendon. This whole system fits very nicely in lace-up athletic footwear. It's not a custom AFO brace. It's a prefabricated brace. It's ordered by shoe size. It fits most patients according to shoe size, except patients who have an abnormally large girth of the lower leg. You can see there's ample clearance of the brace upright coming out of the shoe, but in patients with abnormally large lower leg due to edema, this could be a problem where the prefabricated brace doesn't fit. And in those cases, we ask that you take a circumference measurement and call our lab distributor, and we can advise you whether this brace will fit that or whether we have to go to a custom brace. Are there any questions at this point that I can address with the plantar fascia before we talk about the Achilles? I'll let Sarah or Ann field any questions.
Yes, we do have a couple questions that came in. And if you have one in your head, now's the perfect time to type it in. So Dr. Charles Perry asked, if it helps, then why wait to use it only for recalcitrant heel pain?
Well, that's a great question. There's no question it helps. We all know that there's some patients we intuitively know we're going to get well that come in with early onset plantar heel pain. They're living their life in flip-flops or they're barefoot in their house, and we know we can make some simple lifestyle adjustments, and a lot of those people get better without even going to custom foot orthoses. On the other hand, we have patients who come in that have already been to 2 or 3 doctors. They've had a myriad of treatments, and right away we would think of using the AeroSpring system on them. I would say the only reason not to use the system right from the outset is it is an expensive system. I think to justify the cost of the system, as I'm going to go over with you later, I would think it's going to be a system the patient's going to wear for at least 3 months. And I don't think not all patients need an AeroSpring system to get over heel pain and have to wear it 3 months, but there's certainly a number of them. But I think it's really up to you and your philosophy of practice. There are patients who have an immediate need for relief. and they don't necessarily want to undergo injection therapy. They may not even want to go foot orthotic therapy alone. And so you raise a good point, and I really leave that to practitioner discretion.
Okay. Dr. Cass says, if you're using these heel lifts, aren't you causing a limb length discrepancy?
Yeah, I'm going to go over the prescription criteria at the end, but the heel lifts are always worn bilateral, as are the foot orthoses.
Wonderful. And patients often complain that with a regular orthotic, they pop out of a shoe with those heel wedges. How are they not popping out of their shoe?
You know, that's a great question. I'm going to show you this picture. Because the brace is attached to the foot plate and the orthotic, there's no lifting of the heel. The entire brace and shoe and heel lifts are part of one solid system, and it's amazing. I'm going to show you the Achilles here in a minute. I've treated numerous patients with 20 millimeter heel lifts with the brace, and they don't pop out because of the brace. Now, the problem is the contralateral foot, because they don't wear a brace there, but as Dr. Katz pointed out, they're going to wear a 20 millimeter heel lift, and that's a challenge. They have to put up with just the slippage, I'll be honest with you. Or if they're a woman, they'll just wear a clog with, say, a 10 millimeter lift in just to get the limb length even. They'll wear an elevated clog on the other foot and they're fine. But the men, you put a 20 millimeter lift inside of an athletic shoe, they're going to tend to slip. And they're just going to have to put up with it while they're wearing the carbon fiber brace on the other side. And the slippage isn't that bad where they're getting so much relief on the one side. They actually seem to put up with it. But the other choice is to go to a boot, a lace-up boot, to keep their heel in. And you can wear this carbon fiber brace inside of a work boot, a hiking boot, a mid-cut boot, if the heel slippage is really a problem. But that can be a challenge with the male patients, I will admit.
All
Any
right,
others?
let's see what else we got. If this is off the shelf and not custom, does it need to be ordered from a vendor and is dispensed in the office?
Yes, to both questions, and I'll go over that at the end, okay?
Great. Would you decrease the heel lift over time to prevent equineness issues in the future?
Absolutely, great question. We don't want to leave those heel lifts in a long period of time. As I'm going to show you, particularly with the Achilles, we tend to reduce the heel lift after just 2 weeks. So if they're in a 10 millimeter lift, we try to get them out of the lift after 2 weeks, as long as their symptoms don't come back. With the Achilles, we start at 20 millimeters and we reduce the lift every 2 weeks till we get them down to 0, usually after 4 weeks.
All right. Most athletic footwear will accommodate up to a 2 centimeter to 3 centimeter heel lift. Wouldn't you be sitting above the heel counter of the footwear?
You're going to be close, but I'm surprised with most good athletic shoes, not casual, but good motion control shoes that have deep heel counters, 20 millimeter lift is fine. They don't slip out. They're high, but they're not getting abrasion or instability. If you want to go to 30 millimeter, which I've done, you're going to have to go to a boot, or with a woman, go to a clog.
All right. And one more. With an adult acquired flat foot with heel pain, which is better to control the flat foot or the heel pain? In other words, the regular Ritchie brace versus the AeroSpring.
You know, I think the cause of heel pain in adult acquired flat foot is different than what I just went over. And I think the Ritchie brace is far more effective because it addresses that triplane deformity better. But that's a very interesting question. But in my hands, I'd rather use the Ritchie brace for adult acquired flat foot with heel pain.
Okay, great. And that's it for right now. So if you have any other questions, go ahead and type them in and we will have Dr. Ritchie answer them toward the end. So
okay, yeah, I got about 15 minutes of Achilles and then we'll go into the dispensing. So just as we've learned with these carbon fiber AFOs, we can address plantar heel pain in a more intriguing and perhaps even more effective way we can address pathologies of the Achilles, starting with, believe it or not, the acute Achilles tendon rupture. Also, the more common mid-substance Achilles, boy, that's a misspelling there. I got to fix that slide, tendinopathy. And finally, the ever-challenging insertional Achilles tendinopathy. So we're going to start with Achilles tendon ruptures. And as many of you know, there's a gradual trend in this country, and there's been a trend in Europe over the past 20 years to not operate on all patients who come in with acute Achilles tendon ruptures. In Europe, the gold standard is to not operate on them except a very high level elite athlete. In the United States, there is still a favoring of acute surgical repair, but I think you will all begin seeing a gradual trend, even in this country, to non-operative treatment, because the scientific evidence continues to mount that shows equal and acceptable results without doing surgery. There's a lot of studies published on this. If this is somewhat surprising to you, I always like to look at systematic reviews, particularly those with meta-analysis, but this was one of the early reviews of over 10 randomized clinical trials comparing operative to non-operative treatment. And with meta-analysis, there was an insignificant difference comparing both operative versus non-operative treatment of the acute Achilles tendon rupture. This is a more recent systematic review comparing patient outcomes, and there is no benefit in this review of surgery over non-surgery for these patients who have an acute rupture of the Achilles. This is a more recent systematic review with meta-analysis published in the Journal of Foot and Ankle Surgery, comparing surgical versus non-surgical treatment. No significant difference overall when measuring all aspects of functional outcome, whether it's return to sport, return to work, functional scoring, patient satisfaction. The one factor that does seem to surface in these systematic reviews is the risk of re-rupture. And indeed, we do see a small risk of re-rupture, particularly in highly active athletes who are treated with conservative treatment rather than operative intervention. If we look at all these systematic reviews, patients who should be considered for surgery rather than conservative treatment are those patients under the age of 50 who have a large tendon gap visible on ultrasound or MRI with the ankle in full plantar flexion, patients who have already had a re-rupture, or patients who have an avulsion type rupture, or if they present greater than 2 weeks after the initial acute event. The patients who should be considered for non-surgical intervention are any patient over the age of 50, patients who show good tendon apposition with the ankle in equinus, certainly those who are seen within 1 week of injury, and patients who are at risk for surgery with other comorbidities. What's interesting is whether we do surgery or we choose to treat them non-operatively, practitioners will ask, well, what's the protocol? Are they in a cast for 8 weeks? Are they on crutches for 8 weeks? Are they in a walking boot? And as this review showed back in 2015, there is no agreement across the board in how we manage these patients, whether they've had surgery or whether we tend to not do surgery and manage them non-surgical. I will tell you from my own extensive review of this subject, whether we do surgery or whether we choose not to do surgery, the treatment of the patient from day one after surgery or day one after the rupture is identical. What we're trying to do is offload the Achilles and at the same time facilitate healing of the Achilles. One of the better reviews of all the treatment protocols was published more recently in the Journal of Bone and Joint Surgery by Hutchison et al. And this was published approximately 4 years ago, and they developed what's called the SMART protocol. They show how in Europe, conservative treatment compared to non-surgical treatment is 10-fold more popular. It's not that way in the United States, but it will be, believe me, in the next 10 years. The SMART protocol utilizes a walking boot, holding the foot in equinus from week 2 to 5, gradually moving them out of equinus and out of a boot altogether by 10 weeks. That's a very conservative, rather traditional protocol, but certainly doesn't involve crutches and certainly doesn't involve a plaster cast. The non-operative treatment is identical to the operative treatment in terms of immobilization and positioning the foot in equinus. This was an interesting study comparing plaster cast to functional walking boot with rehabilitation, showing that getting the patient out of the boot and getting the ankle moving early gives a much better outcome than freezing them in a plaster cast for 8 to 10 weeks. So all along, we've always questioned when we allow these patients to bear weight and what kind of protection we should put them in and what position the ankle should be in. And there's no agreement. You will see studies all across the board. But one thing that is agreed upon is that if we can get them out of the immobilizing device early and get the ankle moving and strengthen the ankle, we get a better outcome. Early weight bearing with functional rehabilitation reduces the risk of re-rupture. There's no question. And this is shown in multiple studies, including this recent one in clinical orthopedics and surgery. If we strictly immobilize, we know that we cause weaker collagen synthesis and a weaker tendon. We also lead to skeletal muscle atrophy and weakness. Immediate weight bearing seems to be the newer trend, and by immediate, anywhere from 2 to 3 weeks after injury, with crutches, with partial weight bearing, and certainly full weight bearing by 4 weeks. Complications appear to be lower when we allow early weight bearing, particularly the risk of deep vein thrombosis. So we're seeing more and more studies where they're doing early weight bearing in the conservative management, not just the surgical management of the Achilles tendon rupture. But when they bear weight, the question is, what do they wear to protect the ankle and what position should the ankle be in? We're learning more and more that there's no evidence that severe equinus positioning helps heal the ruptured Achilles. It does bring the torn ends back into apposition, but it may not facilitate healing. Intuitively, and still today, most of us position the ankle in severe equinus during the early days after surgical repair or conservative treatment of the acute rupture. But we've got some interesting studies that shows what happens if we keep them in this position too long. There are fancy cam walker boots that actually can be positioned into 30 degrees of plantar flexion, and some doctors let the patients walk in the boot, assuming that the Achilles is protected. But some interesting studies have been carried out looking at what happens to the Achilles when you bear weight with the foot in full equinus. They placed markers on the Achilles, and using MRI and radiographs, they found that actually there was greater Achilles tension when the patient walked in an equinus boot. That's a boot where they're actually walking on their tiptoe. That's a plantar flex foot plate. That's not a boot that has heel wedges inside. It's where the entire boot is plantar flexed. What they found is it put so much demand on the calf muscle, it increased strain in the Achilles greater than if the patient simply walked barefoot. What we've learned is it's better to leave the foot plate of the boot neutral and use heel lifts inside of the boot to slightly plantar flex the ankle. But keep in mind, a heel lift doesn't always plantar flex the ankle. This was a very interesting study published in our own podiatric journal of foot and ankle surgery, where they took x-rays of a patient inside of a walking boot with various types of heel lifts. And indeed, if you look at the talus, only certain wedges actually plantar flex the talus. In some cases, the talus never actually plantar flexed, with a heel lift only under the calcaneus. The authors discovered that you have to have a full length wedge from the heel to the midfoot in order to adequately plantar flex the talus and decrease strain on the Achilles. So it's this type of wedge system that we use in the AeroSpring brace that we know will plantar flex the talus and reduce strain in the Achilles. But we don't want to leave them in a wedge too long because we want to start loading the Achilles to facilitate collagen repair and muscle activation. We know from studies if we leave the tendon slack, we will reduce muscle activity and slow down healing. Numerous studies have been carried out of whether to bring the ankle back to neutral early versus keeping them in equinus for 10 to 12 weeks. Studies have been done on rat models showing the same effect, that we get immediate atrophy of the calf when we position the foot in equinus too long, reduce calf circumference and calf muscle strength when the ankle is maintained in plantar flexion of 30 degrees for too long. So we really have to move them out of equinus relatively early, and multiple studies have shown that this can be safely done as early as 6 weeks after the acute Achilles tendon rupture. These are the studies that I've seen in the literature, and in some cases, they never put them in equinus. They have them at neutral immediately, but certainly there's a trend to move them out of equinus as early as 5 to 6 weeks. But what's interesting is the use of a carbon fiber AFO instead of a walking boot with heel wedges. And this has been studied by several biomechanists and published only recently in the literature. The most important is the work of Rebecca Kearney and her group in the United Kingdom. And she has studied the use of ankle foot orthoses, specifically carbon fiber, for the management of Achilles tendon ruptures. She used EMG sensors on the calf muscle to measure muscle activity, and she compared traditional walking boots with heel wedges to carbon fiber AFOs. It's very similar to what is used in the AeroSpring system. She found that walking boots still increased heel pressures and caused significant gait disturbances. We know this when our patients wear walking boots. They get hip pain and knee pain, and they don't want to wear the boot. Instead, she found that a carbon fiber AFO with a 1-inch heel raise was all that was necessary to protect the Achilles, limit ankle joint dorsiflexion, restoring a near normal gait pattern. They stated that this carbon fiber AFO with a 1-inch heel raise was adequate to return the patient to function and avoid all the effects of disuse atrophy of the calf, even after acute Achilles tendon rupture. And again, other studies have shown and verified the advantage of using a carbon fiber AFO to offload the Achilles compared to a walking boot. So if we look at all of the research, in my opinion, a carbon fiber AFO can be used inside of a lace-up shoe within 2 weeks after an acute rupture of the Achilles, or certainly immediately when trying to offload Achilles tendinopathy, starting with a 1-inch heel raise. A 1-inch heel raise is 2 centimeters. And yes, you have to apply a bilateral. And yes, they have to wear shoes with deep heel counter and may actually have to move into a low top walking, a lace-up work boot or hiking boot. This is what the system looks like. The brace is worn after an acute rupture for 8 to 12 weeks. We will reduce that raise from 20 millimeters down to 10 millimeters 2 to 4 weeks later, depending on symptomatology and the patient's recovery and feedback from the physical therapist. There is no downside for using the brace longer because if we can get them out of the heel lift by 6 weeks, we will not see disuse atrophy of the calf because now that the foot is at neutral, the carbon fiber brace with the motion in the brace will stimulate loading of the Achilles and loading of the calf muscle. But we definitely want to discontinue the heel raise at 8 to 12 weeks. If the patient has surgery, this brace system can be used as a postoperative management system, identical with the identical protocol if we're treating the acute rupture conservatively. If you don't believe this, I will share with you at least one very compelling case presentation of a 68-year-old female who presented to me with an acute rupture for a tendo Achilles. I shared with her the literature and the scientific evidence and the benefits and risks of surgery versus non-surgery. She chose a conservative approach. I placed her on crutches and a posterior splint with the ankle in equinus for 2 weeks. And then I moved her into an AeroSpring brace system with bilateral 20-millimeter heel lifts. I reduced the heel lifts 4 weeks later, and I started her in an immediate, at 2 weeks, rehabilitation program supervised by a skilled physical therapist. Her functional rehab continued for 8 weeks, and I kept her in the brace for 12 weeks, but I had her out of the heel lifts at 6 weeks. She was more than happy to wear the brace because it was totally comfortable for her to wear, and she felt more secure wearing it for 12 weeks before we discontinued it. It was her left Achilles that she ruptured. And if you wonder if the Achilles can heal with conservative management, here she is doing a single foot heel rise. This is a single foot heel rise on the ruptured Achilles side at 16 weeks post-injury. And this is her contralateral unaffected foot. Definitely stronger on the right side, but she doesn't perceive any significant weakness on the left side. This is a posterior view. This is the ruptured side, 16 weeks post-injury. She has full ability to independently heel rise. This is as good as you ever get with an immediate surgical repair. Her hobby is she's a dog trainer. She does agility training for dogs, and she has to run with the dog. And I want to show you how she runs after the conservative management of the acute Achilles rupture. This is only at 16 weeks post-op. I still see this woman periodically, and she runs much stronger and much better. But here she is barefoot, only 4 months after a ruptured Achilles. That's as good or better than you get with any surgical intervention. Finally, consider using this bracing system for the all too challenging insertional Achilles tendinopathy, which often includes the triad of a Haglund's deformity, bursitis, and an insertional spur. We all know that this is probably the most difficult condition to treat, particularly when a patient presents who's had chronic pain already for 4 to 6 months and has never had treatment. This is one case where I would immediately go to the AeroSpring system because you know you're in for a long haul no matter what treatment. And compared to plantar fasciopathy, this system is well worth the investment right from the outset. There's good evidence showing how simple heel lift therapy does not offload the Achilles properly at the insertional site of the Achilles spur. There is no evidence that a heel lift alone will directly offload the insertional area. The reason is there's evidence that the spur forms from shear stress, from triplane movement of the calcaneus combined with tensile strain on the Achilles. And in our opinion, the combination of a carbon fiber brace reducing overall calf muscle activity combined with a foot orthosis to control frontal plane motion of the rear foot, reducing shear stress at the Achilles tendon insertion, we have a much better chance to offload that area mechanically and certainly bring to bear shockwave therapy or PRP treatments, which in my hands was always extremely helpful in treating patients with chronic insertional Achilles pain. Why not bring all of these to bear, not just a walking boot? While many of us use a walking boot when we use shockwave or PRP, I want you to consider the marked increased benefits of a carbon fiber bracing system with a 20-millimeter heel lift because it's much more efficacious to control the triplane loading and much more patient acceptable. this system alone is much more attractive to a patient than a walking boot. Okay, so the AeroSpring system consists of the carbon fiber AFO brace, a pair of custom foot orthoses, and then graduated heel wedges prescribed by the practitioner up to 30 millimeters, depending on the practitioner preference. In general, 10 millimeters is adequate for plantar heel pain. 20 millimeters is adequate for most Achilles tendinopathy and even acute Achilles tendon rupture. But if you're really nervous about that, we can provide 30 millimeter lifts, but that is a challenge on the contralateral foot. You order the AeroSpring brace by shoe size. And you can trim the brace to fit the shoe in the office setting because it can be trimmed with scissors. It does not have to be ground. The foot plate of the AeroSpring brace has a fabric extension around the carbon fiber foot plate to allow trimming up to one shoe size for customizing the fit inside the shoe without grinding. If you order the foot orthoses, they are made custom and they do require impression casting or scanning, just as you do with any foot orthotic combination. Heel wedges ordered according to practitioner preference, definitely ordered bilateral. The AeroSpring brace system is available only through authorized Ritchie Brace distributors. These can be found on the Ritchie Brace website under the distributors or ordering page. This is the list of distributors who have all of the ordering and pricing information. All of them provide the identical brace, the identical pair of orthotics, identical pricing. They can fax you the prescription form where you pick the system, you designate the shoe size, you designate the heel lifts that you want, and which side you order the brace on. Reimbursement. Presently, the carbon fiber prefabricated brace, depending on what region you're in, will be reimbursed at a minimum of $800 and up to a maximum of $1,000. Custom foot orthoses, as you know, are reimbursed variably. Medicare will not reimburse for the foot orthoses, and I suggest you not bill Medicare for them with this billing package. However, PPO, workers' comp, as you know, many times do cover foot orthoses, and that should be pre-authorized and verified ahead of time. Now, when you do heel wedges, there is no L code for heel wedges, so you charge cash. We suggest charging $20 per set of wedges, $40 bilateral. I've already gone over the reimbursement. It depends on how the foot orthoses are reimbursed, and it can be reimbursed if the orthoses are reimbursed. The entire system can be reimbursed as much as $1,200. That can be either cash or with a third-party payer. The Medicare aspect at least is reimbursed $1,000. The cost of the system, the carbon fiber brace, is about $450, but the reimbursement is about $1,000. And the cost of the wedges depends on how thick the wedges are. You can get all this information from any of the authorized distributors. People ask about diagnosis codes. Specifically for Medicare, we have found that any AFO, whether it's prefab or custom, we recommend you use two diagnosis codes, one for the disease and one for the deformity. So in terms of the Achilles, you describe the disease, which would be a tendinopathy or perhaps a tendon rupture. If it's for plantar heel pain, you describe the disease, which is plantar fasciitis. And for deformity, if the patient has a cavus deformity, if they have a flat foot deformity, or most often they have an equinus deformity, we recommend this code M21-961 or 962, depending if it's right or left. But we always recommend a deformity, whether it's cavus, equinus, or just a simple acquired deformity. In most Achilles, most of you find, and I find it to be true, equinus is present and definitely justifies the use of an offloading AFO brace. We have 4 systems available. Tonight, we talked about Achilles and plantar fascia. I'm going to probably in my final webinar of the year go through drop foot and the very intriguing midfoot offloading system for Lisfrank's injuries and midfoot arthritis. So at this point, I'm going to go ahead and give the screen back to the girls and answer any final questions.
All right, so we are back. Maybe, there I am. Okay, so since Anne was courteous enough to take the first set of Q&A, I will step up for the second. So let's see what we still have open. All right, I'm wondering, I'm sorry, I'm looking at a different screen, so don't think I'm crazy. I'm wondering if a carbon fiber AFO might be helpful in cases of Sever's disease.
I think it would be. I think Sever's, has elements of all of those things I talked about with insertional Achilles pain, plus the element of plantar fascia strain, and as well as just direct pressure on the growth plate. So combining the heel wedge with a carbon fiber brace, I think definitely could be considered. We often resort to cast immobilization with severe Sever's disease. And kids hate to wear a cast. And I think a child would be very accepting of a carbon fiber brace, certainly over the walking boot and over a cast. So that's an interesting application.
Okay. What is the biggest drawback? Is it not covered? I know you covered a little bit on the insurance, but what is the biggest drawback, and is it not covered by insurance?
Yeah, certainly not covered, but it's amazing. AFO braces in general are universally covered. They're universally covered by Medicare, covered by Medicaid, they're covered by private insurance, and they're covered by workers' comp, much more than foot orthoses are. I'll be honest with you, the challenge is you have to order these. We stock walking boots in our clinic, and we use them with immediate intervention when a patient comes in with a fracture and sometimes limp in with severe heel pain. And what's nice is we can implement the walking boot on the spot. The AeroSpring system, you have to order it. And so there's about a week delay. My recommendation is if the patient's in a lot of pain, you put them on crutches. You might consider putting them in a fiberglass cast, but we can get this system to you within 1 week. But it's certainly something you don't generally stock in your office because they're expensive. The other drawback to it is what's already been brought up. If you're starting to put 1-inch heel raises inside of a shoe, not so much on the carbon fiber side because the brace holds them in the shoe, but on the contralateral side, there can be a challenge with heel slippage. It may require them to go to a deeper boot.
All right. The brace comes for one side, but you order lifts bilaterally. Is that correct?
Yes.
Okay.
And you don't always have to do a lift. The heel lift is very optional. I've used the AeroSpring brace with the Archlock foot orthotic system without a heel lift very effectively on plantar heel pain. I will use the lift if the patient has definite equinus, where you measure their ankle joint dorsiflexion, they're at 0, even -5. But if they've got reasonably good ankle joint dorsiflexion, you don't think the Achilles itself, the limitation is there, why use the heel lift? I would go right to the carbon fiber brace and the foot orthotic.
Okay. If a patient has a night splint or a cam walker or an ankle brace, would this trigger a same and similar denial?
Yeah, I knew that question would come up. It would. That's the one problem. If you've already put them in a walking boot, or you've put them in a night splint, it probably is going to trigger same and similar, because even though they're not same and similar, Medicare considers them same and similar. If they're private pay, PPO or workers' comp, there's no same and similar. But Medicare does have same and similar. I did a whole webinar on that. I would direct you to it. You can get payment if you're able to prove to Medicare that the previous AFO, the walking boot, the night splint, has not adequately addressed the condition, that the symptoms have continued in spite of wearing the previous applied brace. And because this is a different brace, it's a different L code, Medicare will reimburse it, but your medical documentation must clearly show that the patient has not gotten better, even if it requires an affidavit by the patient and the patient calling Medicare ahead of time, which is part of what I recommend in that previous webinar.
This is just a question for me on that. What if the device that was originally prescribed, like the cam walker, what if it was damaged? If it was damaged and no longer able to be used?
If it's irreparably damaged and cannot be repaired, absolutely, you can replace it. And that's an interesting question, Sarah, because cam walkers really can't be repaired. Custom braces can be refurbished and repaired, but it's interesting, prefab generally can't. I think.
Could you tell the patient to run it over with their car?
Well, believe it or not, that I've heard those stories. I'm not going to comment on that, but I'll just say I've heard that story before.
Fair enough. I didn't mean it, but yes, was there more that you wanted to say on that?
Yeah.
Okay. Interesting. Okay. Is the AeroSpring brace appropriate for stress fractures at the base of metatarsals?
Absolutely. That's so difficult to offload that part of the foot. And the Achilles is probably the greatest deforming force, bending force to the midfoot and the midfoot joints, particularly the tarsal metatarsal joints. So we're going to talk about that on the next webinar.
Fantastic. On average, how long do you have patients wear the carbon fiber brace, then transition into an orthotic?
I think if you're going to go to the trouble to dispense this brace and their pain has been there, long enough to justify it, which means they've had the pain for at least 2 months, I think they should wear the brace for at least 6 weeks. With the Achilles tendon rupture, I keep the patient in the brace 12 weeks just because I feel better. But with tendinopathy, heck, you can move them out of that brace at 6 to 8 weeks as long as their pain and symptoms have significantly improved. The nice thing about it is you're not in a big hurry to move them out because they don't mind wearing it. They're able to go through their day without all the downside of what a walking boot causes problems with.
Okay, those are all the questions that have come in so far. Quick question that I wanted everyone to be aware of. I know if this is something that's new to a practice, that being a creature of habit and changing process and protocol in a practice can ultimately deter a practice from taking anything new on, because it requires it creates you're throwing a wrench in your current process. So Dr. Ritchie, for anyone who has not had any experience using the AeroSpring bracing system for their patient protocols up to this point, how do you encourage, or how do you best advise them to get started so it doesn't become, oh, well, I know that product is out there, but I just haven't done it, and then it just goes away and never becomes part of the practice protocol?
Yeah, that's a great question. I think the best way is have me walk you through it. And I have the time to do that. I'm retired from clinical practice now. I devote all my time to the Ritchie Brace Enterprise. Sarah has put a very effective consultation page on the Ritchie Brace website so that any of you can fill out the consultation request, put the patient information, the fact that you're thinking about doing the AeroSpring, but you really need some input from me. And I will call you. I'll email you back right away. We'll set up a time to chat on the phone. You can send me patient videos and I'll talk you through it. And there might be cases where I talk you out of doing it and talk you about it doing something else different with one of our other modalities. But I love doing consultations, and I'm usually able to answer them the same day that you post them.
That is true. I know that because I see those get erased from the website. So that is 100% fact. Can you explain how a first-ray cutout with starting over. Can you explain how a first-ray cutout with 4-foot posting, 2 to 5, I'm guessing that means degrees, differs from the arch lock?
Yeah. I had a slide on that I took out just because I wanted to keep this. If you put a 4-foot post on an orthotic, it everts the entire device to the ground. It everts the heel and the forefoot. If you put a wedge on top of the orthotic, it only everts the forefoot on the rear foot. It twists the forefoot on the rear foot. For some of you, that's hard to imagine, but it's absolute fact. So what we're trying to do is twist the forefoot on the rear foot. We're not trying to evert the entire orthotic. Now, having said that, a valgus 4-foot post does tend to put an eversion force on the forefoot, but it also tends to evert the rear foot as well. But I can't deny that it's somewhat effective, but it's much more effective to put the wedge on the top surface of the orthotic so that it doesn't influence the alignment of the orthotic on the ground. Rather, it influences the forefoot to the rear foot only, and it everts the forefoot on the rear foot, i.e. pronates the forefoot on the rear foot.
All right. I'm just going to give a couple more seconds for everyone to get their fingers going fast for last minute questions. But if nothing does come in, Dr. Ritchie, as always, just a fantastic presentation. Oh, got something coming in. Just when I thought you thought we were gonna cut you loose. The Ritchie brace literature is confusing because there are so many braces. Any advice on how to figure out which brace to use? I apologize if you hear my dog drinking water right now. Any advice on how to figure out which brace to use? It seems like tonight you were saying the AeroSpring is universal.
No, I'm not in any way saying it's universal. We have 4 specific clinical indications, which I showed in the slide: plantar fasciopathy, Achilles, midfoot offloading, and what was the other? Drop foot. So, but you raise a good point. We have a lot of braces. So 2 answers for that. First, we have a treatment guide. If you go to the Ritchie Brace website, we have a very succinct guide that shows the clinical indication for each brace. But better, please use the consultation page. I already mentioned that. Go to the consultation, fill out the form, hit send. I will immediately get an email and I will call you and let's chat on the phone and I'll talk you through which brace.
Fantastic. And I was actually going to, in the chat, I'm going to copy and paste the link to the treatment guide PDF so that everyone can download that. So if you want to check chat really quick, you know what, Anne, I can, since I'm not a host, I can only do to hosts and panelists. So if you can copy and paste the link I just did to the entire audience, that would be fantastic.
And you can tell I'm in California and I sat by an open window and barely see me because this is natural light. And guess what? It's dusk.
I guess that's, yes, that's probably our cue to sign off.
Yeah, I'm not going to turn the light on. So
Right, that's a good plan. Well, thank you again, Dr. Ritchie, for your very informative presentation this evening. That was amazing. And thank you for everyone who joined us tonight and who stayed on for Q&A. If you have additional questions, like Dr. Ritchie said, you can go to the contact page on ritchiebrace.com and request a consultation. And you can also check this out again. If this will be uploaded on Dr. Ritchie's website under education webinars, it will also be at podiatrymeetings.com under our Practice Partner Academy archives. So keep your eyes peeled for that. It won't be in like the next 5 minutes, but it will be before the end of the week. And make sure to join us on November 1st, which is a week from today, I believe. And we are going to be doing cash services with class 4 laser therapy. So without any further just energy. I'm exhausted and I didn't even do anything. I'm gonna say good night to everybody. Thank you again, Dr. Ritchie. Anything else from the crew?
Nope. Thank you guys very much for your attention. Thanks for signing on. And just keep your eyes peeled for the next stuff.
Awesome.
Okay, thank
Good
you.
night.
Thank you, Dr.
Bye-bye.
Ritchie.
Bye-bye.
Bye.